really around judging talent. As I grew as a leader, one of the things I realized quickly was having really good people around me was a big factor in being successful. Not in a selfish way, but just in my responsibilities as a leader to the institution where I was working. And I think that when I look back on greatest failures, it's in a process of either hiring or recruiting, not evaluating and taking cues and judging talent before making a final commitment. And once you've hired someone and commit for them to work with you, you're partners for a long time. And in that process, I've learned that many of the things that you see about an individual or understand about an individual's capacity don't change. And they don't change overnight, nor do they change easily. So I think the lesson learned is that two things. Number one, having people who are smarter and brighter than yourself around you is a key to being successful. Number two, in the process of choosing those partners, be selective. Understand that when individuals, although they mean well and there are opportunities, when you realize that there are significant challenges in their leadership style, understand that that won't go away just because you hired them. Now, those scenarios often work themselves out. They're less than what you might have wanted them to be, but many times those individuals work out to be fine. But I would say that's the biggest sense of failure is just selecting partners, whether they're clinical, research, or education. Be thoughtful, be thorough, and then take the practical step of writing down the essential attributes you need out of that individual. Because sometimes in the process of recruitment or making decisions about mentors or partners, you may forget those attributes, but if you write them down, there are things that will be essential for you to make sure you get in that person. I think pancreatic leaks are clearly a part of the life of a pancreatic surgeon, and I've learned to manage them over time as a part of both expectation and a part of recovery and making sure that patients are able to not only have the best outcomes from their operation, but also are able to tolerate the fistula and its process of healing. I think early on in my career, I had an observation because of the vast majority of patients I had a chance to take care of with chronic pancreatitis. We published a series of 42, I think maybe close to 45 patients who had pancreatoduodenectomies for chronic pancreatitis, and there was 0% of leak. And that was an observation that gland texture, duct size, and firmness of the gland really made a huge difference. It wasn't at this time, this was in the late 1990s, there wasn't a lot spoken about, and nor were the international pancreatic fistula criteria established then. But it became clear to me then that if you had a gland that was actually had a reasonably large duct, greater than 5 to 7 millimeters, and a gland that was firm, you could have a close to 0% fistula rate. In the current mantra, I would say that we do understand that to some degree drains probably promote fistulas, but if drains are still used, which I do, I think having them in the proper place and having them serve their purpose of draining pancreatic fistulas is valuable. And then I think the key parts of that for patients who have Class A fistulas is nutrition. For those who have Class B and C fistulas, is really having a team around you who can help you intervene. Understanding that not only antibiotics for antimicrobial but also antifungal may be necessary to treat the systemic symptoms from pancreatic fistulas. So practically, gland texture, duct size, and disease of which you're operating on, a big factor of when you can predict when you're going to get a fistula, and that's important for patients and you to know. Number two, if you use drains, understand that they have a risk of both promoting fistulas but also protecting once a fistula has been established. And then number three, nutrition's important. And then having a interventional team that's a part of your repertoire to drain those fistulas that need to be drained is important for patients' recovery. So I check drain amylases on post-op day 3. Typically, a patient has started a diet. I do not use an NG tube. I do use a drain around the posterior and anterior pancreas. I look for amylase levels that obviously are greater than normal. And if I have a fistula, either by simply qualitative appearance of the drain fluid or biochemical evidence of drain amylase, I leave that drain in place. And for the most part, I've evolved to where I typically feed patients through their fistula, because in the anastomosis, which is the anticolic, either subtotal, I should say, anticolic or with an antrectomy or pylorus sparing, the feeding is fairly distal to the pancreatic anastomosis. And although there's certainly a vagal stimulus for the pancreas, the reality is many people do fine feeding through their fistula. If their fistula output does not reduce over time, I will then move to them to TPN, back to a lesser diet, either liquid or NPO. And then at some point, the drain tract, if the fistula drain tract has been established for a long period of time, the drain itself will often keep a fistula open. And that's when I will end up cracking the drain, or actually moving it slightly so that you allow the fistula tract to begin to close, and then gradually advance the drain out over time until the fistula is completely dry.